I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everybody, and welcome to the April 2016 version of PRS Podcast. Your host, I'm Sammy Sinno, and I'm joined by my resident co-ambassadors, Raj Sawh-Martinez and Amanda Silva. Today, we are very honored to be joined by our guest moderator, Janis. Now, Dr. Janis has so many accomplishments, we don't have time to list them all in one podcast, but we'll say that he's president of ACAPS, ASPS, chairman for the annual scientific meeting, and he is also vice chairman at the Ohio State University Department of Plastic Surgery, among many, many other things. Dr. Janis, welcome to the podcast, and thanks for being our guest today.
Sure, thanks for having me.
All right, great. So I'll get right into the first article for this month. The article is Secondary Necklift and the Importance of Midline Platysmaplasty, Review of 101 Cases by Dr. Narasimhan et al. And a brief overview of this article shows that this examines Dr. Roerich's experience in just over 1,000 neck lifts in their face and neck lift database. In that series, 101 patients had secondary neck procedures either by the senior author or elsewhere. The most common problem encountered in these patients in the chart review was recurrent platysma bands at 87%. They noted that 56 patients had operative reports that were able to deduce the exact procedure performed in the neck, and that the majority that had closed treatment of the neck developed recurrent platysma bands at a rate of 76%. Interestingly, 13 of the 56 patients had open treatment and only one developed recurrent bands. So it would seem that opening the neck has a propensity to avoid one of the most common complications or aesthetic deformities, rather, of surgical neck rejuvenation, that is recurrent bands. The other nice piece of this article is that it shows Dr. Roerich's personal evolution in treating the neck from the 80s to what he now does, which includes medial pication with release of the inferior platysma, his platysma window that he's well described, and direct excision of fat with retention of subplatysma fat in the majority of cases. I thought that this article is a little bit of a hot topic in facial rejuvenation. I think, first, so many people over the decades have described different techniques in facelifting, but now the attention is really focused on rejuvenation of the neck, both surgically and using non-surgical alternatives. And I've always found it interesting as a resident going to meetings and see very seasoned face and neck lift surgeons debate open versus closed treatment of the neck. Some saying they always open and some saying they never open. And furthermore, even the most experienced and prolific surgeons always will say how recurrent platysma banding is one of their most common complications or aesthetic deformities. So I just wanted to open it up to all of you and see what you thought about this article and what are some of your thoughts about neck rejuvenation.
Well, thanks, Sammy. Again, let me start by saying it's an honor to be here with you guys on the PRS podcast, and I really commend you guys for doing something as innovative as this and as dynamic as this. I hope everybody who's listening gets as much out of this as I am. Secondly, when I saw the title, I saw Secondary Necklift, Review of 101 of Roerich's cases. At first, I thought that was just one patient that he revised 101 times, but then I realized that actually it was a number of patients from a pretty robust database, and I happen to know the authors, so just as a matter of full disclosure and conflict of interest, obviously I'm very familiar with all the authors, including the senior author who used to be my chairman. That being said, I think we can intelligently discuss an article like this, and I'd like to highlight, one of the things that you said. But before I get to it, I actually want to ask you guys all a question. When I run journal clubs, I basically ask, as a matter of almost protocol at this point, with my residents, both when I was in Dallas and in Columbus, to divide this article or adjudicate over this article whether this is something that you would keep or whether this is something that you would throw away. And I'm not going to allow any in-between votes. This is not a dimmer. It's a light switch. It's either on or it's off. So knowing that your shelf is filled with books and that your file cabinets, both electronic and physical, are filled with papers, first I'd like to go around and ask you, we'll start with you, Sammy, is this a keeper or is this trash? And by the way, I understand that you might have a conflict of interest with your own since this is a PRS podcast, but you know you're the one who dished it up, so let's eat it. Sammy, what do you say, keep or trash?
I'm going to say it's keep because...
Nope, you don't get to elucidate. I'm running the show here. Come on now. All right, Raj, keep or trash?
Yeah, keep.
Good. All right. All right. Now, I don't want to know any other because Amanda, keep or trash?
I think trash is a strong word, but for me personally, maybe trash.
All right. Well, let's hear from Amanda first. Now we'll go backwards. I want to hear one reason why you would trash it. There may be several, but just the number one thing that why you would say trash. And then just to give you all a preview, Raj, I want to hear why you'd keep it, and then Sammy,
Sure.
why you'd keep it.
So for me personally, why I would trash it is because I think it's a good maybe one-time read from my perspective, especially considering that I personally want to go into microsurgery and I'm not planning on going into aesthetic cosmetic. So it's a nice read for just, a one-time overview, but I don't think it's something I would go back to and reread again and again. It doesn't necessarily have information that I personally feel like I would use over and over again.
All right, so for you, it's basically a practical reason. You're not planning on doing a ton of neck lifts. All right, Raj, what do you say? One thing.
Yeah, I think everyone's going to have complications and cases where things don't go wrong or you'll have an issue down the road. So I think this is actually a nice, honest look at how things evolved over a long period of time that not very many people, I think, are able to really have such a big series. So the one thing I think that I found really interesting was sort of the line here that, the majority of the cases where they had that recurrent platysmal banding was really just that they didn't do any midline plication primarily. So I think that's a big sort of key thing. And there's a lot of other details in the paper, which is why I would probably keep it. But I think that basic information, I think, makes it something that's worthwhile for everyone to sort of keep in their mind when they are doing neck lifts as part of their facelift.
All right, Sammy, last word on keep or trash. Why would you keep it?
Well, I'm very interested in the neck, and I think that I've already seen and performed some procedures in the resident clinics. It's very easy to be talked out of by an attending in terms of whether to open up the neck or not, just to not open the neck. And, I can say that I've seen a lot of patients, even in the clinic, that are younger that actually may not even have too bad of facial aging, but they really do need neck rejuvenation. And I think to see this honest report of his personal evolution and say that, he's had a very high percentage of platysma bands, and when he didn't open up the neck for the first part of his career, that he had an increased percentage of patients coming back with bands, I think is a very important evolution. I think I'd keep it just for that figure that shows his personal evolution as a reminder that to really get the greatest degree of aesthetic control in the neck, you should be opening up the neck.
So I'd agree with that, and actually that was what I wanted to highlight and what I was referring to earlier in this conversation. I think that this study points out a number of things. There are certainly going to be some people who really want to understand the technical aspects of how he's able to achieve consistent results with over 1,000 patients, and especially in the secondary population with over 100. There are others who are going to be interested in the evolution. There are some going to want to understand the complications that can be associated with the secondary neck. There are some that are going to want to be, interested in the patient subpopulations who don't respond and who are more likely to be secondary neck lifts, and a lot of those are addressed within the context of this paper. I wanted to draw your attention to, let me scroll down here, what I thought was, let's see here, one of the most important parts of the paper, and that is, and I agree with you, that at the very end in, I I don't know what figure this is. The figure that shows the evolution, and also the algorithm, which is right after that. So a couple of things, and I'm going to make this somewhat generic, but I think it's an important thing for everybody who's listening to this podcast to understand. When people publish, especially technique-related articles, they stand out there alone in the literature as basically the source of truth. And think about this. How many things do you learn from your attendings at your home institutions, and when you really get to talking with them, especially the more seasoned or experienced surgeons, chances are that the way that they're doing it now and the way they're actually teaching you to do it is not the way they first started to do it when they came out of residency. I think that's actually a pretty rare situation to go through decades in some instances worth of practice and clinical work and not adjust your algorithm and not adjust your thought process and not to adjust your technique. Now imagine that you're not interfacing with that attending across the table from them where you have the opportunity to have a conversation. Instead, you're going to go to PubMed, you're going to go to PRS, you're going to go do a literature search, you're going to look up neck lifts for what you're going to do the next day, let's say with your attending, and you're going to find these papers that exist in the literature as points in time. What we don't have is a journal of retraction. We don't have a journal of what I used to do that I no longer do, which, by the way, I might put a plug in for Aesthetica, to be honest with you. And I have to admit, one of my conflicts of interest is I'm current board vice president of education for ASPS, so I oversee all of the meetings and symposia and actually all the education for our society. And this is going to be something that we're going to bring out in the Aesthetica meeting in June in Washington, D.C., which the title of the panel is Journal of Retraction, What I No Longer Do. So if Dr. Rohrich published his experience after, let's say, 1990, which would be a 4-year biopic of his experience at that time, you might think that this is the way to do it. But like every quality academic plastic surgeon who's interested in their outcomes, Dr. Rohrich has reviewed his experience. He has fantastic photographs, and as a matter of fact, in the acknowledgments section, he's acknowledged Patty and Lisa, who were two phenomenal photographers, and he's able to analyze his results critically and learn from his mistakes, like we all do. Maybe mistakes is harsh, maybe it's how to improve instead, but you see this evolution of his concepts around neck lifting, and currently has been in place now for about 15 years, what he currently does, and now he's reporting on it. I think we can all learn from that. Matter of fact, I wish that more surgeons would do that, follow-ups of their experience, or as a matter of fact, Dr. Rohrich has published on his experience in the past, and now this is the most recent article that says, the way that I used to think about this is different now than it used to be. And therefore, as students in the craft of plastic surgery, I think it behooves all of us to basically understand what is done currently and how has that evolved. I would argue that that is the main thrust of this paper, and although there are other details that are important, I think that's probably the main one in my mind. What do you guys think?
I think it's true. You're basically saying, which I think is very interesting, you can almost learn more from why somebody doesn't do something anymore as to why they do something. And I think you have to have a balance of both. It's very honest. Not many people, in fairness, can say that they've been doing these procedures for 20, 30 years and have such a volume to do that. But I think it would benefit us in not these type of procedures, but anything for people to say this is my personal evolution. I think those are the papers that are often most valuable and telling. What do you think?
I would agree. Now, one last thing before we move on to the next one, because I know we're almost out of time, but, I also am an associated editor for both PRS and PRS Global Open, and so, just to be a critical reviewer of this paper, maybe point out a couple of things or, a few things that I'll leave you with. In the complication rate, there was, or complications section, there was one transient marginal mandibular nerve weakness, which resolved. I personally would like to know how long it took to resolve, and what technique was he using when that happened. Was that an earlier technique with liposuction or defatting directly of the jowl? Was that one of his more modern techniques? I didn't see that in there. I could have glossed over it, but I'd like to know a little bit more about that. There's a few typos throughout here that hopefully would be corrected in the editing process. that I think would clean the paper up just a little bit. I am particularly interested in his use of figure of 8 interrupted sutures. Feldman and others, including one of my mentors, Dr. Barton, does a running suture originally with braided polyester suture, which is what Dr. Rourke uses, but also transitioned later on in his career to a monofilament polypropylene suture. I'd like to know why does Dr. Rourke prefer the use of interrupted figure of 8 braided sutures versus, let's say, a running continuous monofilament suture? I'd also like to know a little bit more about the chin strap postoperative protocol and what the evidence is behind that. And then I'd also like to get some clarification on his use of botulinum toxin for banding. In one section under preventing recurrent neck bands, he talks about using 10 units intraoperatively and 6 to 8 weeks postoperatively directly into the gland. I'm not sure which gland we're referring to. And later on in the persistent and recurrent jowling section, it's almost the same sentence. So I'm wondering if there might have been a typo or if there needs to be some clarification with that. But, aside from that, and I just wanted to be honest about, some of the limitations of the article, overall I think that this is a very nice article, and I'm glad you chose it to review.
Thank you, Dr. Janis. Any other comments, Raj and Amanda?
No, thank you. Great.
Yeah, I think we're sort of out of time, but just curious things to me would be like, the use of Kybella too now. Is that going to affect people who have sort of minimal issues there with just the fat and how that's going to play out? And I was thinking also about the Botox impact on the banding. So thanks for bringing it up, Dr. Janis. And I think we can all see why you've won so many teaching awards.
I don't know about that. I don't know. That's usually just because they take the residents out to dinner. That's how you win them. Are we still recording? Are we recording right now?
Yeah.
All right. Well, forget it. Scratch that. Edit that out.
All right. Well, thank you very much, Dr. Janis. A great discussion.